However, let's just pose the question in two different ways. And Martin, back to you. What about adding anything else like radiation?
So going back to the discussion where Andrew left it, actually, in R0 resection, I think the adjuvant is kind of settled, and hopefully we'll follow the build-up data. And I think when it comes to VA and R1 and R2 resection, I think the radiation portion is an important tool, if you wish, to try to improve in some degree the control of the disease. So either our brachytherapy-like approach, SBRT, or a conformal radiation therapy are things that we can use. Also, you can consider liver-directed therapies in some of the instances to have an NED in that case of the patients when they have at least an R1 or R2 resection.
And so along that line, if anything, this SWOG study kind of, included some form of chemotherapy plus radiation. Teresa, this was done in the US, but curious, how did you read it? And I know that radiation, we know from other diseases like pancreas, is kind of like, it's a question overdone, and that's it in Europe. But tell us a little bit about how did you read the SWOG data?
Yeah, in that, I think in Europe, radiotherapy, it's not so clear, the role of radiotherapy. We can consider after some induction chemotherapy in locally advanced, but as adjuvant treatment, it is never used, I think, or it's not our standard, because we don't have randomized data that demonstrated that.
Fair enough. And by the way, we know that if anything, the radiation therapy question is still kind of, being to be asked, and we know that SWOG is still trying to see what will be the carry-on after SWOG 0809. But with this said, I would like to go back still to the radiation question and look more about timing. So, Andrea, independent of data, if we were to radiate, when?
So generally, I'll give a period of systemic therapy, and then end with radiation. So that's generally my approach. I think the radiation technique has also evolved. Certain centers have a different technique or a different technology. At least we have MRI-guided radiation. So the radiation, if there is a tumor, is very precise. So the toxicity is small. So we now have used more radiation because, in the past we worry about radiation toxicity, certain things such as, biliary stricture and other complications. Now we have seen the radiation toxicity decreased, So we use a little bit more radiation.
Sure. So you, however, leave it till the end, same like what we kind of now vouch in pancreatic cancer. Andrew, your thoughts on that, radiation?
So, two things. When you talk about the biliary tract cancer recurrence, the pattern of recurrence is very critical to select radiation or not.
I like that.
As we know, data from Memorial clearly demonstrated you do have the local recurrence for patients following parahyla, but if you have gallbladder cancer, your risk is actually mainly for distant metastasis. So for that reason, I think, I will have probably lower threshold, for patient with parahyla cholangio undergoing surgical resection to be considered for radiation. But also, I think the margin status is very important. I think clearly R1 definitely, will probably persuade me, to consider radiation more. With regard to the sequencing, there's really no clear data to guide us. But I tend to agree with Andrea. I think for patients who follow the surgical resection, particularly those with positive nodes, I will start with systemic treatments because I do think the risk to develop distant metastasis is probably the major worry for these patients. And then if we actually successfully administer a few cycles of systemic therapy, and then maybe I'll consider the adjuvant radiation at that point. But again, we don't have the right study to really assess the sequencing question.
I love very much what you're saying. And I think Dr. Zhu is bringing up a very critical point, which is really, it all depends on the pattern of recurrence. And same time, I would say that he's bringing a rather indirectly, but very important point about a component of where do, for example, neoadjuvant approach come into play? And what we kind of I like to call is neoadjuvant plus adjuvant, like peri-adjuvant. In other words, something that really covers the surgical intervention from beginning and from end to try to prevent on the recurrences based on the pattern that we just heard in regard to the different diseases. And I'll ask actually if Teresa has any experience, and maybe not, because not necessarily that we have data on this, but thoughts about a peri-adjuvant, or let's call it neoadjuvant therapy prior to resection in cholangiocarcinoma.
Yeah, I think it's a very interesting approach. So I think one of the other things is the multidisciplinary team.
Yep.
So these patients have to be presented in a multidisciplinary group just in order to see if the surgeon say to you, this is very complicated, you have a high volume tumor, I can do it, but, or these satellite nodules that you can say, I can technically do it, but this could be a systemic disease. I think this is the perfect setting to do the neoadjuvant treatment with this. For me, with chemotherapy, probably, or start with chemotherapy, and then let's see if we can go to surgery. But yeah.
Yeah,
so,
Andrew, please.
So I just want to add, we actually designed a clinical trial answering this very specific question. Yep. So the design was very simple. So we give 3 cycles of GM6-based regimen, reassess. For patients who can definitely go for surgery, they will actually proceed with surgical resection. But if not, we will consider other liver-directed treatment, including radiation. The problem is really the enrollment was so slow. We were forced actually to shut down the study. But this type of thinking definitely has been entertained in the past. But I also want to say this approach probably will only be applicable to the intrahepatic cholangiocarcinoma. For distal bile duct cancer, parahyla, this approach is still facing tremendous challenge. As we all know, these patients coming in with obstructive jaundice, they're just begging for something. So if you delay, if you say, we're going to plan a few cycles of chemo, you may actually lose the surgical window.
Yeah. I totally agree. If anything, Dr. Zhu is talking to us about the nice work that he did collaboratively with Dr. Ted Hong from MGH. And actually, in my hat as the head of the chair of the task force, I remember very well that study, which was a great, super well done study. But sadly, the accrual was really limited. And it's back to the same point that Dr. Makaria is bringing up, which is really to bring in the multidisciplinary team into that discussion and make sure that the surgeons kind of know what are the potentials over here and consider really giving that new adjuvant approach before going to surgery definitely will become a challenge. I would say that thankfully we are definitely having a collaborative approach and it's definitely getting better and better. We are very proud of it, all of us. And I would say that maybe our colleagues who really do pancreatic cancer are doing this a little bit more promptly than it is in biliary cancers, but definitely it's on the way. With this said, and we kind of, consumed quite a bit of time on important thoughts in regard to adjuvant therapy, I would say that the best we can hear from this conclusion that we don't have yet a final answer about the adjuvant therapy for cholangiocarcinoma. Nonetheless, it seems all of us by default, not because we have anything else. And of course, want to make sure we do everything we can for our patients who are probably defaulting to the BILCAP study with the CAPS to be in, with an understanding that sometimes, as we just heard in regard to unlimited or rather limited resections within R2 or possibly some R1s, maybe a radiation therapy component can be there, even though SWAG 0809 is still awaiting to see what will be the follow-up for it. And at the same time, we heard about the challenges in regard to a peri-adjuvant, neoadjuvant, followed by adjuvant therapy in regard to accrual, but definitely at least the thought is still on the table and hopefully we'll see it carry on.